It's now time to introduce Paul McNamara. Paul is a clinical nurse consultant in the Consultation Liaison Psychiatry Service in Cairns Hospital. And Paul has been a nurse since the late 80s and a specialist mental health nurse since the mid-90s. He works as a consultation liaison clinical nurse consultant at Cairns Hospital, and he also tinkers a little bit online. I'd like to welcome Paul today to talk about the mental health nurse experience. Thank you, Paul.
Good on you. Thanks, Glenn. Just before I launch into my presentation, I'd like to pay my respects to the Irukandji and Jabberkai people who occupy the lands where I'm on. My understanding is that the Jabberkai people were more up in the hills behind Cairns, and the Irukandji people more around the coast. I'm not sure exactly where I am there, so I'll pay respect to both lots of them. One of the nice things about working up in Cairns is that whitefellas like me get to spend a lot more time with Aboriginal and Torres Strait Islanders than I would in most workplaces. And yeah, anyway, so it's a really lovely part of my role. Cairns is a beautiful place to be at this time of year. The humidity's dropped away a whole heap, so if you haven't got your winter holiday plan, get in with it. Even I know most people will be tuning in from Melbourne, and if you think, oh no, what if I miss out on a game of footy? That's okay. St Kilda are having their round 13 home match up here. And then the other thing I want to make mention of before I launch into my presentation is that I was a bit excited to see that I'm on the program just before Magda Szubanski, one of Australia's most loved actresses. And I haven't made much of a fuss about it, or I might have mentioned it on Twitter and Facebook and Instagram and LinkedIn and my blog and at work and with my family and friends. But apart from that, it's no big deal. The downside to this being an online conference is that I won't get to meet Magda and have a selfie with her, but the upside is if I get nervous and think I'm going to crap myself or wee myself, I can get away with it. In fact, I'm sitting on a commode right now. I haven't got any pants on. That's not true. All right, so here's the presentation. If there's anything that pops up that you think, oh, I'd like to look more into this, might as well grab your mobile phone now and just grab that QR code. That'll take you a link to all the resources. And I'm speaking about the experience that we've had here in Cairns during the COVID thing. I'm not sure if you heard about it, but there's been a pandemic over the last year or so. The Cairns experience probably doesn't marry up all that well with the Melbourne experience, where you haven't had the scary outbreaks, and to the best of my knowledge, I don't think we've had any of our working health professionals here actually catch COVID-19. We've had a few patients come through. The Queensland model is if you test positive, you go to hospital, whether you're unwell or not, and that's because there's an assumption that hospitals do infection control better than hotels. And so far, so good. That's served us well. So these are the four things I'm going to talk about in my quick little session. A bit about my role. If you work in a big public hospital, I imagine you've got a fair idea of what consultation liaison and psychiatry nurses are about, but a lot of people might be tuning in from private hospitals or smaller hospitals or people who work in the community. So I'll go through that. I'll talk a bit about the pivot that we made last year in keeping with the COVID thing, talk about the other PPE, that'll make more sense once we get into it, and finish off with talking about clean hands and clear head. Right, so let's go. So consultation liaison psychiatry services are services which, if you were starting them again, you wouldn't call them that because it doesn't really tell you the function. If you were starting again, you would call it mental health in the general hospital or psychiatry in the general hospital. The Australian CL nurses have been a pretty inspiring bunch to bump into, and so I started finding some of them in the early 2000s when I first started working in this role. And there's been some really inspiring CL nurses around the country, many of them from Melbourne. And so they go into how the actual role functions. And some people have got really quite creative around it and have been able to extend the role. Like there's a guy called Chris Dorber who's got an interest in clinical supervision, and his role as a CL nurse, he's done a lot of supportive clinical supervision groups or reflective practice groups with midwives and oncology nurses and a few other people around the place. Clinically, the stuff that takes up our time, I'll call the 7 Ds. And the 7 Ds are around delirium and dementia. It's surprising how often delirium is not recognised in a general hospital. And sometimes we'll get phone calls which will be like, oh, you know, Mr. Smith, he's a couple of days post-op and he seems to be really confused and is hearing things and seeing things. Do you think it's a psychiatric stuff? But it's nearly always, you can tell by the phone call that that would be a delirium if he hasn't got a history of psychosis. So, so with delirium and dementia, we're lucky in my hospital, we've actually got a standalone team that handles delirium and dementia. So nowadays, for the last, I'll say about 5 years, we've been able to divert those referrals straight through to them. We see a lot of people with depression. It's the most commonly experienced of the mental health problems, depression and anxiety. They often go together. And hospitals cause their fair share of depression and anxiety too. We see people who are admitted after deliberate self-harm and require either a medical or surgical admission. Sometimes that deliberate self-harm is suicidal, but not always, of course. And I guess part of our role is to help the patient and sort out what that self-harm meant for them and what can we do to help them go forward. I've never really taken count. I would imagine less than 10% of the people that we see who are admitted after deliberate self-harm are transferred to the mental health inpatient unit. Often that's not the best place to do your recovery from that sort of crisis. Disturbed behaviour, it bugs me a bit, but I kind of get it. If somebody's really angry or upset, or particularly if that's high expressed emotion, the staff will often look to mental health to see if we can help out. Look, nearly always those sort of high expressed emotion don't necessarily have a seed in a psychiatric illness. It could be about distress or intoxication. Somebody's just angry or maybe have a bit of delirium or dementia and are perceiving the people who are there to help them as threats. Dangerous diets, we see, spend a lot of time with people who need a medical admission to safely overcome starvation syndrome. And so we see them in the general hospital and support them, and probably more to the point, support the nursing team in particular and the dietitians and the medical team as well, support them to support the patient. And then the last one I've got there is dodgy drugs. And I don't necessarily mean illicit drugs there for North Queensland. I think it was Carolyn on that panel with Heather, Carolyn and Wendy earlier on mentioned that far North Queensland's got a big drinking culture. Sure does. So alcohol would be by far and away the most common drug. And then also the prescribed stuff, like if you come in with an inflammatory illness, COPD or whatever, and you need high doses of something like prednisone, that can tip you into, psychosis or mania or depression too. So they're the sort of presentations we see, and it's nice and varied. It's an interesting job, and if you're wondering what to do when you're a grown up, as I am, this should be something you should consider doing. It combines my background as a general nurse and as a mental health nurse nicely. I feel like I've got a foot in both camps. So that's the role. If you want to find out more about consultation liaison, I'd suggest just Googling ACMHN, as in Australian College of Mental Health Nurses, a CL special interest group, and that'll bring up that page that's in the middle there. Some good information. Right, on to pivot. You might remember it was one of the words that was being used a lot at the beginning of the pandemic, around March last year, where people were pivoting. And And I think pivot is a word that's a bit more palatable than saying change, adapt, or survive. My favourite example of pivot was just down the road from me is a gin distillery, Wolf Lane Gin. If you're in Cairns, give it a try. And we were there the night before we went into lockdown. I think it was around the 17th of March, give or take. And they were selling all the gin that they could at the time, but we're also saying, by the way, we can make hand sanitizer here. And it was a lovely little example of pivot. I think it didn't take them long to work out that everybody was sitting around home drinking more than usual, and they probably pivoted straight back to making gin. But anyway, they did that little pivot from giving their attention to gin to giving their attention to hand sanitizer. For us who are CL nurses, we did a similar thing. We kind of pivoted away from our focus being on hospital patients and focused a bit more on hospital staff. Just going to pause here for a moment. When you're a bloke in nursing, you've got to be really kind of mindful of the sexist stuff. And I can see this sexist thing there. I bounced it off a few of my female colleagues and my female partner, and they all thought it was okay. I still feel it's a bit creepy. But anyway, with the CL nurses, my colleague is a female and is a straight female, and so that she wasn't being creepy, even if you think the fat middle-aged bloke before you is. So we were able to pivot away from hospital patients because, well, they stopped coming to hospital. All the elective surgery was cancelled. The nurses who had been surgical nurses were suddenly, bang, you're the COVID ward now, which I'll talk about a bit more in just a moment. And so the hospital was, I've never seen it so quiet, even after cyclones. When we get big cyclones, everything goes quiet for a few days. But this was eerie. It lasted weeks and weeks, and it's quieter than a cyclone. And so we were able to, we had that luxury of being able to spend some more time with our colleagues than what we normally would. Normally we're facing the hospital patients than the hospital staff. Which brings me on to the next section, the other PPE. I stole this completely. I spoke before about the surgical nurses pivoting from being surgical nurses to all of a sudden having to be experts in infection control and respiratory illnesses. And them, together with the respiratory ward nurses, came up with some lovely ideas. And I want to share some of the ideas that they came up with and that they shared with us when we were chatting with them. So I stole the whole thing. I stole the phrase positive practice environment from the union, the nurses union, and just repurposed it for this. So hopefully I haven't buggered up too many copyrights there. The first thing that they spoke about was team nursing, and particularly that, you know, they weren't all that, the surgical nurses in particular weren't super confident with the whole donning and doffing thing, and so they were working in pairs, so there was always somebody there to watch you and make sure that you'd gone through those steps right. Once you were in an isolation room, you always had a set of eyes on you, so if you needed something, they could come in and help you out. They said that as a team, as nursing teams, they were much more cohesive and much more conscious of helping one another and working in those dyads, in those pairs, to support the patients. And that was a real strength, they said, and something that they took a lot of comfort from, because they said that it was pretty scary, particularly in those early days when nobody really quite knew what was going on, being in an isolation room there and wanting to make sure that you weren't bringing an infection out of that room and amongst your colleagues or back home. Communication was the next one. So the nursing teams had time to sit around and talk to each other on how to make this new normal work. And so it was amazing how many of them said that they, for the first time, they got to know their colleagues who they've been working with for years and years for some of them, but didn't really have time as a group to sit around and share information and share ideas and share their anxieties about stuff. if you weren't anxious in March 2020, when you were a nurse, you weren't paying attention. But that communication, they said, was a real strength, not just within the nursing team, but they said, with the respiratory and infection control consultants and the other medical staff, that communication between them and the nursing teams picked up a lot too. So that was a real positive. They spoke about working smarter, and they came up with some great ideas. My favourite one was that everybody in an isolation room had their extension number written on the window to their room, so you could phone them without going into the room and speak to them there. They got the tech guys to come up and rewire the bedside phone, so if you picked up the phone in the bedside, you would be automatically dial the nurse who was allocated to your room. So just some really smart ideas there. For me personally, I didn't have to use PPE at all during that period. I did all my reviews of patients in isolation over the phone, using a phone, and would look at them through the window. So we still had that eye contact, and it worked pretty well. I still use that now for people who aren't in isolation for COVID. But if they're in isolation, rather than trash a set of PPE, I usually use that as my first go-to. Getting smarter was a lot about upskilling, finding out what they could about what was going on with the COVID stuff, but making sure that they were getting that through appropriate and credible channels, not swamping themselves with social media, which was a big part of staying focused, and that there was so much information swirling around that a lot of them described it as being like a racehorse who had to put on blinkers, and we just really need to look at what's going on here and not get distracted by all the stuff that was going on either side of us. And then the bit that I liked the most out of the insights that I got from these teams, and just keep in mind that these were nearly all women, young women. I don't think any of them would have been under 40. Most of them were under 30. Most of them were under 30. I might have been a few over 40. I was never courageous enough to ask. But they came up with these terrific insights. And one of them was this, is that downtime is sacred. And they said that, like, you come home from work and you understand it where, partners and family and friends want to know a bit about the COVID thing, but they got in the habit really early in the piece of just shutting that down and say, look, we've had enough of the C word at work today. I don't want to be talking about it in my time off. The final bit, and this will be pretty quick, is talking about picking up on something that Julia Baird said earlier on in the morning about taking moments to look after ourselves as we go along. And what we came up with is that most nurses wash their hands about 27 times a day. And so why don't we make that a moment for us? Hopefully the video explains that well enough.
A trick that's worked for me is taking a mindful moment intentionally during the day. We all wash our hands about 11,700 times a day, and so if we use that not only to keep our hands clean but to clear our head, we're getting two for the price of one. So I'll run through what I do, and maybe it'll work for you. Let's give it a go. So I'm just taking a mindful moment. I'm stepping towards the sink. I've got intent. This is my mindful moment. I'm taking a brief break. First up, let the water flow, and I feel that water washing over both of my hands. The water's warmer than the air. The water's warmer than my fingers. It feels good. Add a little bit of soap. It's slippery, frictionless. Fingers feel fine. Start with the cleaning. The first half of my hand hygiene is just about washing stuff away. Get rid of the anxiety, get rid of the tension, let it wash down the sink. Next half of my routine is restoration. It's time to put in some healing and some care and get on with it. I check into my breathing now. I make sure that it's slower and deeper than it was before I started. If it isn't, I spend a bit more time. Now I slowly scan the surroundings, and with any luck, somebody from infection control is watching and they're thinking I'm doing a great job. Have a little smile. I breathe slowly. I'm rinsing my hands off, and I'm turning off the tap now, and I'm going to make like Tay-Tay. I'm just going to shake it off, get rid of that excess water. Dry both hands with the towels. throw the towel in the bin with my troubles and get on with work. Cheers.
So that was the idea behind the clean hands, clear head thing. I think nurses have always been pretty good at hand hygiene, but 2020 was probably a high point for us. We've never been better. And if you find washing your hands is helpful to have as a mindful moment, maybe that's something you can take away from this presentation. Thanks for tuning in. I've enjoyed it, and give my love to Magda if you happen to meet her face to face.
Paul, are you still with us there?
Yeah.
Terrific, thank you. Thanks very much for your presentation. I have a question that I'm really keen to ask a fellow mental health nurse. I'm just curious to know, there've been a number of nurses or a number of colleagues with us today who potentially are considering a move or are curious about the mental health area of working in mental health. How would you summarise that, and how would you sell that to them?
Yeah, look, do it. Even if you don't think mental health as a specialty, you're going to use the skills you acquire in mental health training wherever you work. Yeah, and I used to be an ICU nurse and went from that really high-tech environment where there wasn't much of a emphasis on sitting around chatting to people. It was about doing stuff. But I really like this low-tech environment. I really super aware of that privilege that you get with chatting with people and hearing their stories, a bit like I've forgotten his name, the really impressive guy.
Matt Ball.
Thanks, Matt Ball. Yeah, that was talking about. My job is mostly listening. And people have amazing stories. Yeah.
Sorry to interrupt you there. I think I think I've said this previously, but it's a very underrated skill that we have, all nurses and midwives and frontline workers who, and particularly in these sort of areas where our personality or our skill set is the key components to potentially de-escalation in an environment or a setting which could be quite volatile. Is that something you've noticed?
Yeah, I was laughing when Kim was presenting herself, when she was talking about people acting in roles and feeling uncomfortable with it. I often talk about a big part of my role is impersonating a calm person. There's often where I walk into a situation where I really don't know what the right thing to do is, so I'll impersonate somebody who's calm until it comes to me, and that's been a fairly good strategy so far.
That's a really good strategy. I think I might have used that once or twice myself. I've got another question. Paul, I've been a CL nurse for approximately 1 year. Love the job, but find that I am running from pillar to post. Do you have any other tips for managing time during this busy job?
Another thing I stole from people wiser than me who said it's really worthwhile spending time backburning rather than running around putting out fires. And by that, I think it's really useful to share some of the skill sets and some of that confidence that we have managing people who are going through often the worst day or two of their lives, sharing that with the team at the bedside. Because if they feel a bit more confident, they won't feel the need to necessarily handball it straight to you straight away. We can still be there to support them, of course, and but yeah, putting in that time around that back burning and upskilling the people who are already there, already supporting the patient.
Time. I might use that. Thank you very much. I think we have one more. We'll have time for one more question, and that question will be from me. If I could ask you to ask a young Paul one question, and that be how did you see this all sort of working out? Asking young Paul that question, what might that answer be?
I I honestly don't know. I never meant to be a nurse. It was all a big accident. I just thought it'd be nice to be a bit helpful, and I think I've wound up in a job where all of us are pretty helpful, and that's nice. It's nice to do a job where you walk away most days thinking, oh yeah, look, I've been helpful, and I've getting paid to do that. So that's never going to be a millionaire, but okay, it's a good quality of life.
I think that's a really good point you raise, and I think if we've got that, then we're really we're halfway there. Look, thanks very much again for your time, Paul. It's been great to hear your insights into the profession and to your experiences, and we will pass on your regards to Magda.
Good on you. Thanks, Glenn.
Thanks a lot, man.